Palliative care matters, because palliative care isn't just a specialty, it's something we all do. Subscribe wherever you get your podcasts. Welcome to the next episode of the Palliative Care Matters podcast, and I'm very excited to be joined for this episode by two colleagues from Kenya, Dr. Esther, and from Ethiopia, Dr. Nuhamin.
Thank you. I'm Esther Nafula. I'm a palliative medicine physician. I currently practice in Kenya. I also head the pain and palliative care unit at Kenyatta National Hospital, which is our largest referral hospital in the country. Thank you.
Yeah, thank you. Thank you for having me and us, Jane, on this episode. My name is Nuhamin Gebre. I'm a family physician and currently pursuing a PhD in palliative care research. I am a member of a technical advisory team for palliative care for Ministry of Health Ethiopia. I'm a clinical academic, so I also do teaching and developing curriculums in palliative care in Ethiopia.
Thank you so much. I'm going to jump to a question about careers. For many of us who have developed a career in palliative care, we've kind of had to define those steps, career steps ourselves, and find our way through. And one of the exciting things for me in talking to you both is that, you have both done that very successfully in your different settings. And I think it would be really helpful for others to understand a little bit more about your career to date, what helped you, maybe what challenges you've experienced as doctors.
So I trained as a family physician, as I mentioned earlier, and when I was doing my electives during my family medicine training, I had the pleasure of joining a hospice team. So the team had experiences in home-based palliative care. They were also working with the university hospital that I was part of.
So yes. You did your family medicine training in Addis, and yes. This hospice was in Addis.
So this hospice is based in Addis, as you said, which is the capital in Ethiopia, and it's serving about 300 patients per year, and it has grown, of course, since it started, and is now helping other university hospitals and other institutions like primary healthcare facilities grow in palliative care capacity, clinical, and also like research. Yeah. So when I started, so that was in 2017. It was an elective for few of us in the training, but since then it has become part of the curriculum for family physicians in two of the university hospitals or family medicine programs. It is now a part of the rotation, so everyone has like at least 1 month of exposure in the hospitals mainly, but sometimes also in the communities or primary care facilities to see patients with palliative care needs and to be part of a team that has the clinical expertise and gain some teaching as well. Yeah.
Great. Are there other specialist programs that will go through hospice?
Yeah. So far it's just family physicians who have this like formal program. It has been the case since 2016 that the Ministry of Health has a 5-day palliative care training or course that is accessible for oncologists, internists, and other physicians, not just physicians actually, multidisciplinary teams, so nurses, social workers have been part of, and pharmacists have been part of this training, therefore.
I'm just going to jump to Esther and ask, is that at all similar to your experience, Esther?
So for me, my path is a bit different. So my first exposure with palliative care was as an undergraduate medical student. We had a 3-day training just prior to our elective term. And before then, I would only hear the palliative care team being called in to see patients, but I didn't understand what it was all about. So during this training, we were taught a bit about the holistic nature of palliative care. And when I went for my elective term, I was doing a surgical rotation. and the hospice nurses used to come in and manage the pain of the patients. One afternoon, I sat in with the nurse as he was doing an assessment for a young boy post-amputation with osteosarcoma for pain. And I was quite impressed at the length of time he took to understand the boy's pain, and then prescribed for him morphine. And the next day, he was able to be discharged home because he had been labeled as a stubborn patient. And the nurses in the ward were saying all medications we give are not working. So I asked if I could spend some time in the hospice. So now during the days I was off from the rotation, I would spend time at the hospice. We would go for home visits. I would join the support groups. And so I came to understand what the training was about. Now, when I was doing my elective term, this was 2011, we had fewer hospices, maybe about 10. So after now, I graduated and did my internship and got licensed as a doctor. And then I did a higher diploma for palliative care by Oxford Brookes, which was being done by Nairobi Hospice. While now I was doing the diploma, and I started now meeting doctors who are working in palliative care. So we had one registered palliative medicine physician that was in now 2014. He had done his MSc at Dundee. He encouraged me to pursue a career in palliative care. I actually wanted to do radiology. I was a bit confused at that time between doing radiology, oncology. The palliative care path was not straight. So I was being encouraged to do palliative care, but it was not very clear. So I applied to Oxford Brookes University for an MSc, which I joined in 2016. Completed in 2019. Then after that, I had to do supervision under the palliative medicine physician for 6 months. Then after that, now I could be given a license to practice palliative care.
And is that the same in Ethiopia? Can you register as a palliative medicine specialist yet, Nuhamin?
We don't yet have that qualification or job description. So far, family physicians are the ones who are actually providing the service. Of course, we have internists and oncologists that are integrating the approach in their, of course, respective fields at this point. We have introduced the service to primary care and home-based services, but not yet kind of recognized as a specialization in terms of qualification.
Yes, it's quite a big step forward, isn't it, to be registered as a palliative medicine specialist. I think it varies in different from country to country, doesn't it? It's just one of the, I guess, many milestones in terms of how easy it is for people to enter the specialty.
So first I was given a senior registrar license. So the senior registrar license recognizes that you're training and being supervised in that field, so in palliative medicine. Then now after 2 years, 2021 is when I became registered now as a palliative medicine physician. So for us in Kenya, palliative medicine is recognized as a specialty. You can do it straight through an MSc. A regulatory body accepts you to do a 3-year MSc, then supervision after that. Or you can do an MMed followed by a fellowship in palliative medicine. So it is a specialty, also a subspecialty. So once now, like I have that license, my current job description is actually palliative medicine.
And can all that training, the masters, because you did it in Oxford Brookes and your colleague in Dundee, can that all now be done in Kenya, in country?
Not yet. In fact, we are just in the process of getting our first fellowship accepted. So probably the first ever fellowship in palliative medicine will be hosted by our sister referral hospital, Moi Teaching and Referral Hospital, from September. But again, the fellowship is for subspecialization. So it is for someone who already has an MMed.
Okay. So they'd need an MMed in whatever surgery, internal medicine, obstetrics, whatever, and then, or family medicine, and then they would do the fellowship. And the fellowship is how long?
2 years. And the mode of training is going to be blended so that we can allow the fellows to spend some time getting the lectures and then some time getting mentorship. So the approach is to have them continue working in their workplaces as much as possible so that they're doing clinical placement where now the palliative physicians are. People doing fellowships are have families, have
Yeah.
bills to pay, so it is very
Yes.
hard to get them.
No, I mean,
Yeah.
you talked about your exposure to hospice as a family physician. Can you tell
Yeah.
us how things developed for you from there?
So then I was part of the faculty of family medicine at Addis Ababa University, where I saw the need because I was working in a tertiary hospital, referral hospital, and of course patients were coming with advanced disease, of course advanced stages of cancer, advanced HIV, and in organ damage because of many of the chronic conditions. And then I was writing protocols in terms of how we can further develop the palliative care service in the hospital, also continue to work with the different NGOs and community-based organizations.
Was there a
Mm.
hospital palliative care service, or did you have to kind of set that up from
Yeah,
scratch?
set that up from scratch.
Okay.
So when I was just completing my family medicine program, there was one room being allocated for palliative care service. So together with my colleagues, we were there as clinicians a few days of the week, providing palliative care service as well as teaching it at that point to family medicine residents.
Mm.
And we actually needed, because we were very few in number, needed to establish like a consultation based service, go to the different wards, OPDs, and emergency room to provide service. The leadership was encouraging us for sure. Like as any service, we needed to advocate for ourselves and for the service patients could access within the facility. But
It's a lot to do, isn't it? Can I ask you what kind of helped you in your career? Esther, you've obviously mentioned this particular a nurse who took that extra time with a patient.
Yeah, so of course now that nurse continued to mentor me until a point when I finished my master's. Then I met the palliative medicine physician. I met other nurses who are now leading the academic programs in the country. Those have mentored me over the years, and again I got mentors now academically when I went to Oxford Brookes. And I think what I loved the most about palliative care compared to other fields of medicine was just the personal touch from the colleagues who had gone ahead. So
Great.
people would always, yeah, they would always create time to just help you to navigate the space. And that's what is very beautiful about palliative care, because even in the work environment, we actually create time to listen to our colleagues and just to hold each other's hand. And that's what has really helped me to grow in this field of palliative care.
Nuhamin, any comments from your side on that?
so I'm part of a technical advisory team for palliative care for Ministry of Health and for the Regional Health Bureau as well. So working in with that team with colleagues was I think the best thing. I didn't have to carry the burden myself, or my colleagues also had, and we had each other. And the team at Hospice Ethiopia was helpful, as I said, as pioneers. They were always helpful to encourage.
It's great. Any particular barriers that you want to share?
The first barrier was the lack of understanding of what palliative care is. I would get a lot of comments from colleagues that I was working with, because the program at Oxford Brookes was a blended program. So I would hear people ask me, when you complete this master's, what are we going to call you? People would ask me, why are you specializing in this field? Don't you think you should have done something like surgery or fields that people know?
Mm.
Some people would ask me, so what exactly are you coming to do for the patient?
Yes.
The barriers were
Yes.
just basically lack of knowledge from lay people and also from healthcare providers. Second
Colleagues.
thing
Yeah.
was finances. As you've heard, my journey, I was studying in international universities, so I also had to raise funds to be able to meet the obligations of school fees.
Wow.
Fortunately, I managed to get a full scholarship from the university. So
Mm.
whatever I had paid, I was funded, but that is not everybody's story. So sometimes, yeah, the training is actually very expensive and still inaccessible. So we have doctors who could be interested in training in palliative care, but they don't know where to train, especially if you have to sponsor yourself. It was difficult for me navigating now after specializing before I went into government practice. I was actually doing private practice, so that was freelancing.
Yes.
Because most institutions didn't understand, where do we need to place you? How do we pay you? We keep on doing continuous education and then working also with the Ministry of Health. It has been continuous advocacy and then also mentoring others. So like now, I think 4 registered palliative care physicians. You see, when I was starting my master's, there was only 1.
Yes.
In fact, I used to really doubt. Yeah, sometimes when people would ask me questions, I would also sit and reflect and wonder, what if I'm making a mistake? You see,
Yes.
yeah. So the field is also growing and there's so much opportunity. So it's just the constant talking about it and then mentoring the younger people to know
Yes.
what we are also doing. Yeah.
It's hard though sometimes, isn't it, when you kind of study at medical school and even your families can kind of expect you to have a slightly more smooth career path, partly in terms of finances, because there is that hope that you'll be earning a reasonable wage, and when you come to specialist training and you're having to pay more money to complete that training, it's not easy, is it, always for people to fully understand what you're doing when it's not as clear perhaps as some other specialties, and maybe other specialties have more option for private work as well. But yeah, I think there's quite a lot. Nuhamin.
Yeah, I think when we started, because we didn't have a clear service model, I think we had to try what would work, and we had to learn a lot from the mistakes along the way. So I think in terms of implementing the service, the lack of local evidence at that point for service models was one. In terms of training, still we don't have specialization for it. Therefore, as we said earlier, it's still the basic introductory course or elective courses that we have. Therefore, we don't have the critical mass to kind of showcase the impact. And of course, now it's improving. The lack of essential medications, I know, is a problem in many settings, and we're not able to relieve the immediate suffering that we see, the physical suffering or pain, that, and therefore we're not able to provide holistic support.
Do you still have problems with morphine supply in Ethiopia?
Unfortunately, yes. Yeah, and we have leaders that do understand the impact palliative care has for patients that cut across disciplines, and but sometimes we need to convince other leaders, and we need to be patient as their priorities change, and we still need resources allocated for the service. And again, like leveraging resources in the communities is not always straightforward, as we again need to advocate and create awareness, and it's often asked. I guess the patients are not primarily of the palliative care units, so it might be difficult to convince some funders that we would show impact by the service we're giving.
Yes. Is there any particular advice that you would want to give those who are thinking of pursuing a career in palliative care?
Yeah, talking from my experience, I think after identifying the need for it in my system, I am still part of a PhD program with King's College London in palliative care research. And I know we're talking about clinical care pathways, but I believe the skills I got from this research program or PhD program is helping me where the impact as clinicians focused on the patient and, of course, immediate clinical outcomes. But we can, I think, in palliative care, supporting Ministry of Health and advocating for patients across levels of care. So I believe parallel to the clinical expertise, skills in research would be useful for clinicians to mentor others in terms of priority needs that that we identify.
Esther, any thoughts about advice that you'd want to give?
Yeah, I would actually tell them to start early so that they start understanding what palliative care is. They should be willing to grow personally and professionally, because palliative care would really help them as doctors to foster compassion, to learn new skills, And of course, we deal with a spectrum of patients all the way from neonates to geriatrics. So there is actually a lot of learning and research that needs to be done. So they should seek out mentors and then, of course, just start volunteering a bit. Yeah, because also volunteering within the hospices or palliative care units will also help for them to understand what actually goes on, so that they are not just imagining what happens when a palliative care patient is brought. So the exposure would be really, really good. That's what I would advocate for. Before I specialized, I had volunteered in 3 different hospices. I had sort of started to gain an understanding of the value of palliative care.
Is there anything else that either of you would like to say before we finish?
I think in palliative care, I have learned that we need to be patient. The impact may not come right away, and the career path or the job descriptions may not be clear when we venture to this discipline. So I think to take it one day at a time, one program at a time, one course at a time, or one patient at a time. Then, as Esther said earlier, like work in teams, be encouraging each other along the journey, and be encouraged that you are advocating for a patient and compassion, and you are like living what you vowed for.
Great, thanks, Nuhamin. Esther?
We do what is possible for our patients, and it reminds us daily that we need to show up for our patients. Even when we cannot cure them, we still need to provide interventions, we still need to care for them and walk the journey with them. So we never abandon our patients, and that's what is very beautiful about palliative care.
As you say, being that human face or that compassionate face or that caring face, the job satisfaction, I think, sometimes is, yes, we have to face the fact that mortality is real for everybody, and patients do die, and we have to deal with that, but that is part of life, isn't it? And the fact that we can accompany people on that journey, as you say, and help people to live as actively as possible until they die is also, it's I certainly found it very fulfilling, and it's been great to hear both of you talk about your career to date and also the work that you're doing to advocate and continue to develop services where you are. So thank you very much to both of you. Palliative care matters, because palliative care isn't just a specialty, it's something we all do. Subscribe wherever you get your podcasts.